do not like to wait too long for a long time, Ugo Ture.
It's okay.
But I want to show you some hotspots. The first was impressed me was Leonardo da Vinci's work, of course. I'm a big fan. I like to paint, as you know, my anatomical sketches, and I like his work. And he was dealing also with the temporal lobe. So from there, we need the landmarks. Without landmarks, we are completely loose. And I agree with Vasiliki Xenaki. Without good landmarks in this area, you will end in the pallidum, you will end in the brainstem. I'm talking, of course, for the beginners, for the young residents in our group, and your president of the Hellenic Neurosurgical Society, my friend Akis Fatsoglu, told me that there will be also young residents around the corner during this webinar. Myself, I had a big hero. He was not a neurosurgeon, but a climber, Reinhold Messner. He climbed without using artificial oxygen the Mount Everest as the first human being. Why he was a hero? Because this picture you see here, the first solo ascent from a unique man climbing Mount Everest, means resilience, patience, risk management, risk of management, and endurance, of course. And this is very, very, we can see in a parallel way to our field of to do good, maybe almost perfect neurosurgery. So the temporal lobe in the 50% of all the cases, you see the slides now, yes?
Yes, very clear.
Yes, 50% of the cases are arising here. So in the adult epilepsy surgery, we are dealing in 75% with the temporal lobe. In children, with the extratemporal locations. You see here the different approaches, what we have today, and today we focus on the left inferior part of this sketch. Corbini and Brodmann published the neurocytoarchitectonic fields of all the lobes, and we have also be aware that his nomenclature is still valid after almost more than 100 years. More than 100 years, was published 1909, as you can see. And Vasiliki pointed out also the agonal band of Broca, the band of Giacomini here, and all this, the gyrus intralimbicus, etc., so on. With one of my students, I performed a morphometrical analysis, and we found, interestingly, what we know in the meantime, of course. So they are different. The broadest one is always the middle temporal gyrus. The smallest one is the superior temporal gyrus. This is the classical picture obtained by Professor Yazagil's book, The Philosophy of the Transylvian Approach via temporal stem, or the inferior approach via collateral sulcus, as published by Shimizu for the first time in Japan. And Vasiliki pointed out this important structure here. So here you don't find cisternal structure. The cistern finishes here behind the amygdalon. So it's very difficult to find the end and the border to the pallidum and the putamen. I discussed this topic sometimes with Professor Ugo Ture, and he comes from here, as you know, the transtoral approach, and this is maybe the best view to the amygdalon, to the complex of the amygdalon. But he will talk about this. And Adolf Meyer, as you know, he was a psychiatrist, immigrated to the United States in the middle of the 19th century, to New York City, a psychiatrist, and he described for the first these loops coming from the lateral geniculate body and running around the temporal horn and back to the striatal area. Adolf Meyer, therefore, Meyer's loop. And we all know the modern reconstruction of the Meyer's loop fibers. First of all, the studies of Klingler in Basel, you know, white matter dissection, fiber dissection, and then our techniques in MRI diffusion sequences, approaching diffusion sequences. This is a picture I want to rest a couple of seconds or 1 minute, if you allow, because for me, this is crucial, of crucial importance. Why? Professor Yazagil demonstrated that from carotid artery, from middle cerebral artery, from P2, the second segment of the posterior cerebral artery, from P3, coming many of vessels to the hippocampal structure. what we have to do here, we have to remove in this area the hippocampus, the parohippocampal gyrus, the amygdalon in epilepsy patient. In patients with temporomesial tumors, we have to remove the tumor and let in place the brainstem here, And Ujimura from Japan, he was a guest doctor at the Institute of Kaiser Wilhelm Forschungsinstitute at Munich at that time under Vogt and Spielmeier, and he published a fantastic paper. Of course, you know, Professor Yasagil always cited his work in his book, 1996, of Ujimura. Ujimura's arteries are the arteries, the candelabra-like arteries coming from P2 and running inside the Ammons horn. Also, later, Henri Duvernois from Besançon in France, he republished this topic. This is of great importance for us. You see here Ujimura as a young guest doctor, Vogt, Spielmeier, Lady Vogt, etc. so on. So it was the fantastic time, the fantastic period of this Institute of Research. Later became, changed the name to the Max Planck Institute of Neuropsychiatry. So you see here the original paintings. So this we have to know. This we have to know. We have to avoid to cut the branches of the posterior cerebral artery, including the anterior choroidal artery. And Vasiliki described nicely where the anterior choroidal artery is entering over in the anterior choroidal point into the lumen of the ventricle. So we have to expose these vessels here, these Ammons horn arteries, as described by Yushi Ujimura. We have to elevate the hippocampus. And you see later, you have to elevate the hippocampus, just cut these vessels here and let in peace anterior choroidal artery. The same is for the draining veins. So Professor Yasagi showed this in his volume, Microneurosurgery, 1996. Why he elevated the hippocampus. So the intellectual rationale behind is Ujimura's artery complex. So the arteries supplying the hippocampus and the branches of the veins running to the basal vein of Rosenthal. You see on the right side, Friedrich Rosenthal, basal vein of Rosenthal. Rosenthal was an anatomist at the Institute of Anatomy in Greifswald, northeastern Germany, former communistic part of Germany, as you know, a very important and very interesting institute. And he published this famous, every medical student knows the famous basal vein of Rosenthal. The basal vein is Rosenthal is running with the optical tract here, and the draining branches we can cut. But to do this, we have to expose the choroidal fissure. We have to elevate the hippocampus. There's a trick, and I've seen a spatula in Vasiliki's picture. You have to a little bit to elevate the hippocampus to just cut these veins and these arteries here. And then you are safe. Then you feel safe. This is the case for tumor surgery. This is the same for epilepsy surgery. Henri died a couple of years ago. Also, he did an amazing work, and if you plan, I'm talking now for young people, if you plan to do some neuroanatomical work, please go back to his original books and you will find a goldmine of information. This is the basal point of view. Again, the draining branches to the basal vein of Rosenthal, and the same is with Ujimura's arteries. So to put away a little bit and higher the hippocampus, then you will feel very, very safe. At the end of resection, we have a look to the optical tract. We have the exposure of all these veins. I show you what we did in a study. At the end, you feel safe. You can climb this mountain without fearing lethality or mortality. So, of course, we have to know, and Axel Panetsky showed me this, you have to know the importance of Labe, vein of Labe. The temporal lobe is the most mobile lobe of all the lobes in the brain. You cannot mobilize the parietal, the occipital, the frontal like the temporal lobe, because he is very attached just via basal veins to the tentorium. It can easily be mobilized. And the importance is, if you put some traction, of course, the story of the transmedullary veins, you know, this famous picture of Professor Yasser. This is the border of the draining system to the superficial veins and to the deep veins of the vein. We published this. This was an epilepsy patient, animation of the superior anastomotic vein of Trollard and the collateralization to the Sylvian vein on the right side. And you see how important it is to have a picture of the veins, especially if we do some implantation of grids into the brain. At the end, this is brainstem, what we have to preserve or enter in the case of a cavernous malformation surgery in the middle of the brainstem. There, the lateral mesencephalic vein can offer us a nice and fantastic guideline. So we described different types of these veins. And for the first time, we described vessels running to the lateral mesencephalic vein. So the target is always make free this here, the anterior, middle, posterior tentural incisure, cistern vein of Galen, and the cistern of Galen. This is, by the way, the posterior border of resection in epilepsy surgery. You have to resect the hippocampus until the level of the fourth ventricle. Before, please don't stop, because if you don't resect the hippocampus under this level, the seizure freedom of patients is lower than in complete resection, of course. Another point for young people maybe is interesting. If you go along the tentorium, you're not, if you are in tentorial notch, you are not at the end of the parahippocampal gyrus. Remember the swan, or the hippocampus, the head, the abdomen, and the tail of the hippocampus. Yeah. So go over, but please remain behind the arachnoid fissure. Professor Yasser always told us in Zurich, in the operating room, this membrane was created by God for neurosurgeons. So this follow inside, go subpially resection, then we can remove from this notch, we can remove the whole parahippocampal gyrus. Shorter story, Penfield was the first to perform complete temporal lobectomy. Then Oscar Niemeyer, just using the glasses, lobes, was operating more than 50 cases with 78% seizure freedom at that time without microscope. Falconer decided to go back to the bigger resection, and my life, most of the time I used the anteromesal approach, a modified and very small corridor along under the T1, also under superior temporal gyrus. And Professor Yasser published the fantastic selective amygdala hippocampectomy. I go faster now. You know all these pictures. This is from Yasser's book. This is my own drawing. You know, remain always lateral from the middle cerebral artery. If you go into the temporal stem, the incision in the temporal stem, to reach the view of the branch of the foot of the hippopotamus. This is the second etymological explanation of the term hippocampus. You know, hippocampus is related to the coronary view of the seahorse, parallel to the seahorse, and hippopotamus is the brain. And we found in our last study nice inferior insular vein in the sulcus limitans, inferior sulcus limitans, marking the deepest point of the insular cistern. And from there you can enter. Just cut Ujimura's arteries here, even in tumor surgery. Let in peace anterior coronal artery or P2, etc. So on. Electrocorticography, I go faster now. There are always many times benign lesion in this area, benign lesion, fortunately. And this was an impressive patient for me because he was handicapped by, his wife was handicapped by Contergan, so suffering from phocomelia, but she was able to find me via internet. And this patient was followed with 40 years of terrible seizure story. A simple lesion here, as you can see on the left side, a simple decembroplastic neuroepithelial tumor, completely benign tumor. So you see why we use the veins. The venous anatomy in these days of the digital techniques are very helpful. You see here the completion, seizure onset. This was a post-traumatic epilepsy, vein of Lobe, Sylvian, vein of Trolar, speech, motor function, and you can see at the end the resection line. So if you use, as Vasiliki underlined, if you have good landmarks in your life as a neurosurgeon, you will be safe and you will feel comfortable. It's it's easy comparable to the climber. This mountain is between Munich and Salzburg. In my area here, every year 3 or 4 people die down here. When instead they go, this group goes here, and the lethality is much more lower, much more low, significantly lower. And this is comparable to neurosurgery. And at the end of the 42 years, when I started my work in Salzburg, I decided to go back to my former teacher in biology, Reinhold Messner, with my former Salzburg team to visit him. And I think we should go a little bit faster now. I want just to tell you, young people, please invest energy. Still, it's worth it to invest energy to try to understand anatomy. We have a lot of wonderful books from our pioneers. Do you know all the names? Yazagil, Roton, Evandro de Oliveira, Hugo Tire, especially in this location, Hugo published a fantastic amount of wonderful papers. And I hope that I was able to show you some interesting thing. Last slides are more personal, more dedicated to young people in this round. So what stimulated me other than Reinhold Messner, the climber? One was Alexander Panetsky, by the way, the mentor and teacher of Akis Fratzoglu. Also, for a certain time, he spent under Axel a certain time in Mainz. And Axel was a pretty good guitar player, and we decided sometimes to play together. For example, during a national meeting of Germans in Munich, we produced this CD in 1999. Now I play more with professional musicians. I learned from my daughter. I show this picture because last week I had the chance to see her on stage in London, England, and it was so emotional and so fantastic to see how these young people is training hard, 9 hours, 10 hours a day, but at the end they are successful. So, and we as neurosurgeons, we need this. We need to train, we need to go back to the laboratory, as Professor Yazagil always taught us, go back, dissect hundreds and hundreds of brain and try to understand more better. At the end, you will be funny under a microscope and during surgery of a patient if you feel comfortable, if you feel safe in terms of microanatomical landmark. We are just unique in your field of neuroscience. We as neurosurgeons have to understand neuroanatomy and functional neuroanatomy behind. Nobody does it. Not the neuroradiologist, he makes black-white photos, but some of them were outstanding and fantastic. Remember Pierre Lajonias or Alejandro Berenstein. But at the end, we have to understand these landmarks. Lenza, like our daughter, she has to understand every movement, the notes. The same is in playing jazz. So we had not the chance to rehearse together with Axel and myself. We came from different continents, but at the end, we had a good basis and a good intellectual basis, and we started to improvise. And this, as a retired man, unfortunately in Austria, I had to retire at the age of 65. I feel still fit and good, but it's the law. And then I decided to organize some meetings for people, for normal people in my Bertland in northern Italy, to understand more, to explain more this interaction between brain and music and these parallels of different professions like neurosurgery or ballet or playing music. When I was in Salzburg, the chance together with Rahman Al-Jameri, he's now in Saudi Arabia, a very skillful and very good neurosurgeon. endovascular and microsurgical men. We organized many of these courses and meetings. Now I established this course in Berlin, invited by the group of Berlin. The next course will be maybe interesting for young people, November 14 to 16, 2025. So we go inside the dura. We not just perform craniotomy during this course. We go inside the dura, and step by step we try to really to show all these structures I tried to show you during my lecture. I thank you so much for your attention. Wish you all the best. Thank you. Ευχαριστώ.
Thank you, Professor.